I want somebody or anybody to read this out for me. Who wants to read that out? Okay, so you're all clever clogs. You all worked out how to read backwards. But that's not health literacy, is it? That's your ability to read backwards or your ability to read. And I think with health literacy, it's useful to think of literacies. So are you literate about the aged care system? Are you literate about the financial system, budgeting and planning for your future and superannuation? Are you, when you go to another country, are you as confident to find your way around there? So literacies can be in different topics, and what we're talking today is really health literacy. And here's a simple definition for you, which, and I wonder how it compares with yours, but it's the idea that health literacy is knowledge, it's skills, it's confidence, and it exists in networks of people. We heard this morning from Elizabeth that people go to families and friends for information. So if their health literacy is low, then that's where you're getting the information from. So it's not just an individual health literacy. It can exist in networks or where people go for information. And it's necessary. Why do we care about health literacy? We care about it because we need it to stay healthy, to access preventive screening, to decide on what treatment, to self-manage, to communicate. Now here's a complicated diagram, and I've put it in for two reasons really. To make the point that if you have low health literacy, you're less likely to be able to access care, to be able to communicate with your provider, to be able to self-manage your condition. And if you can look at the top box, I don't know how to point to just here, to these sort of social determinants of health. We don't have education in here, but we should. That if you have a low income, if you're not employed, if you don't speak English, then it can be difficult for you to access healthcare. Agreed? But it also can mean you're more likely to have low health literacy. So you've got the double whammy of a barrier in terms of social determinants, but also more likely to have low health literacy. So it disproportionately affects people who are disadvantaged. And the other point I want you to take away from today is that it varies from person to person and it's dynamic. It can change over your life course depending if you get an illness, then you need to learn all about that illness. So health equity is difficult to address. It's difficult for us to increase someone's income. That's not within our remit or control, but we can do things to reduce the health literacy disadvantage. So, as you will have just discussed earlier, there are many different definitions of health literacy and there's no right one. There was a systematic literature review done and it found 17 different definitions of health literacy and 12 conceptual models. So there's no one way and it's become a catch-all phrase. So really, I think the thing to take home is that if someone says the term health literacy, you might be talking cross purposes. Oops, let's go too far. So the related concepts of health literacy. So if you don't speak English and you get an interpreter, then that's great. You can then understand what's being said, but if you have low health literacy, you still won't understand the conversation. So addressing a language difference isn't addressing health literacy. That could still exist. Culture is an important concept because we might have different understandings of health. For some people, it might be connection to country, family. For other people, it might be more the biomedical model. So, and we come from professional cultures too, and we have expectations within those professional cultures about how we communicate and what our role is and what our responsibility. And that isn't health literacy so much, but it is a related concept because it might be how willing you are to ask if someone's understood you, and what you believe is the role of the patient in this situation. So a term that we quite like is cultural humility, and that just recognises that by us being able to reflect on our role as health professionals, to look at the power imbalances, and to think about the reflection of the role we're having here provides an opportunity to address not only health literacy but some of these related concepts. So if we're going to have a responsive healthcare system, we need to address health literacy, but that alone is not sufficient. We need to address language barriers, and we also need to look at cultural humility. Now, this next slide, I don't necessarily want you to read through, and you can get a copy of the slides if you want, but it's really just to make the point that where can we intervene? We can intervene at the individual sort of professional level, or we can also intervene at the organisational level. And if you are interested in culture and language, I know Barbara Louise and Vesna are doing a session after this, a cultural immersion session, and that's where you could get more information about that. So I'll hand over to Naomi.
That's all right. We just wanted to briefly highlight as well the statistics. So I'm sure that you've probably all seen the statistic from the original health literacy survey that was done in Australia in 2006. So that was a fairly simplistic one, and it found that around about 60% of people didn't necessarily have the skills and capacity to be able to effectively understand all of the information that was being provided and be able to act on it. Just to highlight as well that in last year, the ABS did a new health literacy survey based on a health literacy questionnaire. That's a much more complex framework for analysing health literacy, but it did actually pick up that there were some areas that were a little bit better this time around, taking it to that next level. And as you can see, one of the statistics was that around a third of Australians found it always easy to discuss health concerns and actively engage with healthcare providers, and 56% found this usually easy. So that's a positive step. But the whole statistics can be found in the recent ABS release, and there are actually 9 different domains that were measured for that, some of which were not quite so positive as those. And when we do talk about health literacy, we are increasingly kind of reminding ourselves that we need to think about it in a much broader sense than just about individual health literacy. So individual health literacy and the health literacy of a particular person is an issue, and there are a certain range of strategies that you can take to try and improve that. But we also need to think about the environment. So we need to think about what kind of barriers are we putting up in place within the systems, the processes, the physical environment, and think about how we might actually reduce the complexity there. Because as we know, there's been some dramatic changes in the health system over time, so everything is changing and evolving. So processes are not static, systems are not static, technology is changing all the time. And people are now expected to have a much greater role in their care as well. So the expectation about consumers and their capacity and what they're able to do at home or between appointments or to maintain their health is increasing as well. So we need to think about those types of things and how we can address that. And this is a diagram that I like. It's a little bit old now, but from the US, which just indicates the amount of decision points even in a very simple process about attending a GP clinic. So there are so many kind of decisions that need to be made in order to actually get you to that appointment and think about what you need to say and how you're actually going to achieve an outcome. And while it might be easy for us who work in the health system who understand all of the different options, there are lots of different barriers that can be put up for people with health literacy. Sure. So we wanted to ask you a question. So thinking about this process, about attending an appointment, what do you think the barriers might be that you could see in this particular pathway that relate to health literacy?
Can you see?
No? Okay.
Okay, so I've got some handouts here. So what it highlights is, so at the starting point,
You need to find a practice and schedule appointment. And then before you visit, you need to think about what is the reason for your visit, what are the tests you might need to do, are there medications that you might want, or are you on medication at the moment that you need to talk to your doctor about. When you get to the practice, you see the receptionist, so you need to interact with the receptionist and explain why you're there, and you may have to provide information. There may be insurance discussions or payment discussions, forms that you need to fill out. When you're with the doctor, you need to have the conversation. So you need to be able to explain the problem, talk about your health, your family history, all of the different factors, including your preferences about care or treatment options. You need to discuss the options, and you need to think about and have an interaction about what are the risks and benefits for the different options that are available to you there. And you need to be able to kind of weigh up and ask the questions that might be pertinent for you in that situation. And then there may be a discussion about referrals or ordering tests or what the next steps might be. Then in some cases you might need to see a practice nurse, so there may be some education that's provided or information that you need to take home and think about and make a decision on. And then you need to leave the practice, and then there's the whole leaving processes around making sure that you've made the payment. Is your payment going to be covered by MBS or not covered by MBS? So there are lots of little decision points in there which can be quite challenging for people. So thinking about that, what do you think might be the barriers?
If you put your hand up, okay, great, we've got some at the back.
I'm from Child and Family Health Nursing. Jane and I actually went to Rhodes Peninsula yesterday, which is a whole community of... Jane's next to me, sorry. Which is actually a whole community that is in isolation, and they actually had a representative who was Mandarin Cantonese speaking. She was there as a representative saying that a lot of the people there actually don't speak English at all, and one of the problems, they don't even know how to get to point A.
Yep.
So they can't even get on that actual circle yet because they don't speak English. So I think one of the things is we're trying to work out how we can actually help them to actually get to point A.
Yep.
I work for Healthy Homes and Neighbourhoods, and one of our biggest things is financial and like transport.
Mm-hmm.
Like if they don't have any money, they can't actually even get to the GP.
Yep.
And they've got little children, and so we get one of the big things we've found is getting them 1-3 sick.
Yep.
Has been huge.
So I've heard there a language barrier, knowledge that a service exists barrier, and then a transport and an income barrier. So they're sort of related. They're not all health literacy, are they? It's coupled in with other barriers to access to healthcare.
There's 2 questions down here.
Sorry, my name's Lara. I'm from Sydney Local Health District. The barrier that I've seen in working in aged care is a lot of cultural sort of barriers where people from certain cultures just don't want to ask for help at all. Or they don't want to go and see a doctor. They don't want to. They don't want resources coming into their house. Health workers coming into their house. And the language and access to a computer.
So if we think that improving access to healthcare means going into people's homes, but for some cultures that's not appropriate.
ACAT assessor to come in to tell them about the resources. So
then maybe that. Yeah, it's an organisational health literacy barrier, I think. We've made an assumption about what patients want, and they've told us something different, so we might need to reorient our care.
I'm Denise Fry from Sydney Local Health District Community Health. I think one barrier we often forget is emotion. So when people are hearing a diagnosis, which is upsetting and confusing and frightening, all of us have trouble actually taking in information and hearing and understanding.
Excellent point. And that comes back to the point that health literacy is dynamic, that if we're anxious or shocked, we won't be able to take in the information. Jeff?
I think there's also an issue of cost for some people. If you can't find a bulk billing doctor, then that becomes a barrier, as does the medication that you might need out of that. but also whether or not the doctor you want to see is actually, that knows your case, is actually available. In my mother's case in the country, she would have to make a medical appointment a month in advance in the hope that that would be a convenient time to actually see the doctor, because you couldn't see her doctor any quicker than that. In my case, my doctor is available sort of a couple of times a week, so it's fine if I want to see my doctor and she's available, but a lot of the time she's not. So there's some structural things in there as well.
Yep.
Hi, Salima from Dental Hospital. I'm retired, but I deal a lot with aged people doing voluntary work. The biggest problem I find is that with aged people, they call up to make an appointment. The first thing they get told is a waiting period. The doctor is busy, so you might have to sit around. I mean, that up there is pretty busy. It's too much for someone, with an ordinary background to take all that in. They make a phone call and they can't get an appointment. It's, they get told straight away, it's busy, so they put the phone down. How do we solve that?
Well, I think we're running out of time. I just got... What are you saying?
We've got a 10-minute, but this gentleman had a question.
No, just a comment. Anne, my wife, is a GP. For her, one of the biggest issues she tells me about is that the medication that they're on is that little white pill.
Yep.
They don't know what the little white pill is.
Yeah, definitely. Okie dokie. So there's quite a few challenges, but then if you're a health service or you're a clinician, where do you start? Because there are lots of different things that you could actually do to address health literacy. There's so many different strategies and different points at which you can actually intervene. So you could do things like health literacy surveys. You could find out more about the needs of your patients, work on communication techniques. You could look at your physical environment and your signage and your wayfinding. So sometimes it is a little bit hard to think about where you actually start. I'm just going to skip.
Okay, so what I learned from you was that health literacy isn't just a patient responsibility, it's very much a system responsibility, and that we need to reflect on how we provide care and what impact that would be, and that it's very complex for people to understand. Now, I think we've got an understanding of health literacy and the different dimensions of it. I wanted to just spend some time talking about taking action. And you've got the slides, and in the interest of having an interactive session, I won't go through them all, but the next slide will show you that if you wanted to address health literacy in the community, you might want to build community health literacy on how to stay healthy. If you wanted to work with individual patients around self-management, that might be your outcome. In terms of healthcare organisations, you may want to make the system easier to navigate. So, and there are mechanisms for doing that. And I just wanted to talk through health service providers. So the mechanism that's often talked about there is teach back. Who in the room's heard of teach back? Okay, some of you. So teach back is the idea that you ask, once you've in a consultation, once you've explained something, you say, so as a test of how well have I explained it, can you tell me in your own words what I've said? And the patient repeats back to you what they've understood from the conversation. So, and it's very clear that it's not a test, but that it's, how well I've explained it to you. And what happens if they don't understand? What do you do? Keep repeating it and repeating it. Like, it's a good audit tool, it's a good check for understanding, but it then doesn't say, well, what do I do now? Do I call in the nurse to come and draw a diagram? Or so I think that's a step in the right direction. It's important, but not sufficient.
Yep.
So next slide.
Okay.
I'm not trying that.
Okay, so I'm just going to very quickly just say that when we talk about health literacy, so we at the Commission have done a couple of papers around it, and what we talk about is trying to take a kind of multifactorial approach, and the areas that we try and focus on are making sure that we take action to embed health literacy into systems, integrate it into education, and also try and support effective communication. So embedding into systems, I'm going to talk about very briefly in a second, but it's about things like inter-standards accreditation, curriculum, or at a local level it could be policies and processes. You can support effective communication in a range of different ways. So it's about, on an individual level, providing kind of information that's written in a way that's appropriate to the level of health literacy of the person, providing it when people need it and in different formats, and other kind of different strategies. And also there's a range of ways that you can embed it into education. So we at the Commission, as a way of kind of incentivising change and of supporting system change, we've actually integrated health literacy in a lot stronger form into the second edition of the National Safety and Quality Health Service Standards. So in the first edition, there was a couple of actions that talked about particularly health information, but in this second edition, we've actually got a whole criterion around health literacy, but we've also weaved it throughout different standards. So there's actions about signage and wayfinding, about sharing decisions and communicating critical information. And when we explain it to people, there's generally, even though there's a lot of different actions there, there's some general principles that we talk about. So a lot of these go to understanding what consumer and community needs are. So understanding who your community is, and at an individual level, what that individual patient in front of you, what their needs are, what their preferences are, what their goals in that circumstances are. And then tailoring and designing improvements, whether it be at an organisational level or whether it's about improving or developing a care plan for that individual patient, or developing treatment, or sharing decisions about what's going to happen. And then also we talk about making sure that you actually test the improvements, or you test the care plans that, or the processes and treatments that you've developed, and make sure that it's actually fit for purpose, that the information you've developed in collaboration with consumers is fit for purpose, that the treatment plan that you've developed while sharing decisions with the patient has actually meeting the outcomes and the needs for that patient, so that you're all achieving the original goals.
So I want to spend a minute on the practicality. So we know quite clearly that if you don't speak English, we heard before from Jane and others about that. We've heard that it's complex to access healthcare. So we know this, we've got this knowledge, but yet taking action and change is difficult. So I don't know if you want to reflect for a minute on why you think change is so difficult. I can talk about it at two levels. One is at the service and organisational level. We're not just dealing with one objective ever. We might be trying to improve health literacy, but we're also trying to reduce costs at the same time. The other issue is that we don't always know the impact of a decision, or it can have unintended consequences. And the third is that sometimes we make assumptions. We use mental shortcuts unknowingly. So we might assume, for example, that people speak English and will be able to access a service. Or we might assume that if our idea is good enough, if we've got the right idea, then change will just happen. So I don't know if anyone's brave enough to reflect on this, but what at the service and organisational level, if we know what we need to do, if we know health literacy has a big impact on access to care, on communication, on self-management, if we know change needs to happen at the organisational level, at the individual level, at professional level, why? And we've got standards as incentives. Why is change so difficult? Is anyone brave enough? Great.
We're also busy.
Busyness, okay. It's a good point.
It's not an excuse.
Yeah, no,
We're busy and we've got benchmarks we have to achieve.
Yeah. So we've got other competing priorities, yeah.
It's all because there is so many things that need to change. So it's not just one thing that you do to improve health literacy.
Yeah.
There's so many things across the system.
Yeah.
So it does take a lot of things to be measured, I guess, as strategy.
Yeah.
There might be changes in one area, and then it's slower to change in others, so it doesn't impact the overall.
Yeah, so change isn't just one strategy, is I think what you're saying. There's a whole range of things that need to occur. And respecting that mechanism for change. If it was easy, we would have done it by now.
Yeah, the biggest problem though is that Australia has become so multicultural that there's so many different cultures and different languages now that even putting out a brochure like we had at the dental hospital,
Mm.
to produce a brochure that everyone can read.
Mm.
You can't just do it in English, and it's not just one language, it's so many different languages.
Yeah.
How do you correct that?
Yeah. Well, I don't think you correct it. I think we recognise the complexity that that we don't just have one group of people, that there's a range of people we need to engage with, and I think having a diverse workforce that reflects the population we serve is a good first step. And I don't have the answers. I'm just recognising, when you go to workshops sometimes it all seems so straightforward, but I just wanted to recognise the complexity. So at a provider level, if you're running a service or you're, a general practice, if you want to make a decision, it might be whether to refer a patient or not, whether to prescribe or not. But if we want to address health literacy, we might need to modify the way we do things. We might need to think about how much time we allocate to a practice. We might need to think about, if we're going to use teach back and they're not understanding what's our strategy then, are we going to get someone to help navigate the follow-up referral or appointment that needs to happen to provide that extra scaffolding so that people can access the services they require. So I think the opportunities that we're left with a good understanding of health literacy and the related concepts, the real opportunity is to recognise that we can have inherent biases or assumptions that mean we don't see the whole picture. We need to put in measures to improve decision making. And I think having the social groups in the room who are going to be affected by this is a good start to getting those different perspectives, and also reflective practice. There's an article there by the World Bank that actually audited some of their attitudes to working in country and their beliefs, and that really showed some of the assumptions that were made that weren't useful. So this is our last slide, and at this point, you were going to ask Naomi for feedback.
So we're just going to ask, having gone through that presentation, was there anything, how did your view of what health literacy was at the beginning of this session, has it changed? Were you thinking along the same track? Were there any new issues that were raised in there? Or do you have any thoughts about what you're going to do when you leave? Or we could leave you to think about that.